Welcome back to Pediatric Case Review. Today, we're tackling one of the most dangerous metabolic emergencies you can encounter in a newborn, Ornithine Transcarbamylase Deficiency, the most common urea cycle disorder. Could you recognize it before the ammonia climbs past the point of no return? Over the next 14 cases, we'll move from the sleepy neonate in the nursery all the way through long-term follow-up, diagnosis, emergency management, genetics, and transplant. Let's get into it. Case 1. A 3-day-old full-term male, uneventful delivery, APGAR 9 and 9, a baby who looked perfectly well at birth. Since day 2, poor feeding and lethargy. On exam, he's lethargic, hypotonic, and tachypnic. Glucose is normal at 70. The pH is 7.52, a respiratory alkalosis, and the ammonia is 890 against a normal under 110. Pause on this combination. A previously well neonate who deteriorates after feeding begins with a high pH and a sky-high ammonia. What's your leading diagnosis? The answer is C, a urea cycle disorder. The classic OTC story is a symptom-free interval, then onset on day 2 or 3 once protein feeding loads the system with nitrogen. Ammonia stimulates the respiratory center, producing the early respiratory alkalosis, a clue that's easy to miss. The normal glucose argues against a fatty acid oxidation defect, and there's no acidosis to suggest sepsis or an organic acidemia. Look at the comparison table. Very high ammonia, normal glucose, alkalotic pH, day 2 to 3 onset, that's urea cycle disease until proven otherwise. OTC is the most common of these disorders. Case 2. A 2-year-old boy with known OTC deficiency comes for routine labs. Ammonia, 340, elevated glutamine, low citrulline. His mother asks a fair question. Which enzyme is actually missing, and what does it normally do? Look at the 4 options describing different urea cycle steps. Which one is OTC? The answer is A. OTC transfers the carbamoyl group from carbamoyl phosphate onto ornithine, forming citrulline. When OTC is missing, carbamoyl phosphate piles up in the mitochondria, spills into the cytosol, and is diverted into pyrimidine synthesis, which is why urinary orotic acid rises and becomes the key diagnostic marker. Option B describes arginase, C describes CPS1, and D describes argininosuccinate lyase. The biochemical signature: high glutamine, low citrulline, low arginine, high ammonia. Remember, OTC is a mitochondrial enzyme expressed in liver and intestinal mucosa. Case 3. A 6-month-old boy is diagnosed with OTC deficiency after a hyperammonemic crisis. Both parents are unaffected, but a paternal uncle died in infancy with encephalopathy, and a 4-year-old sister appears healthy. The parents want to know the recurrence risk. To answer that, you first need the inheritance pattern. Which is it? The answer is D, X-linked recessive. The OTC gene sits at XP11.4. Hemizygous males carry a single affected X and tend to have severe early disease. Carrier females are variable. Random X inactivation means some have enough normal OTC, while others, with skewing towards the mutant allele in hepatocytes, become symptomatic. Roughly 15 to 20% of carrier females develop hyperammonemia. For this family, sons of a carrier mother have a 50% chance of being affected, daughters a 50% chance of being carriers. The paternal uncle's infant death fits the X-linked pattern perfectly. Case 4. A 5-year-old girl with 2 episodes of unexplained vomiting and confusion after high-protein meals, normal in between. Ammonia during an episode was 320, and OTC deficiency is suspected. Both OTC and CPS1 deficiency give you high ammonia and low citrulline, so those won't separate them. Which single investigation best distinguishes the two? The answer is C, urinary orotic acid. This is the one test that splits them. In OTC deficiency, the block is distal to carbamoyl phosphate, so carbamoyl phosphate accumulates, shunts to the cytosol, and drives orotic acid production. Urinary orotic acid is elevated. In CPS1 or NAGS deficiency, the block is proximal, before carbamoyl phosphate is even made, so there's no substrate to shunt. Orotic acid stays normal or low. Both share low citrulline and high glutamine. Orotic acid is the only differentiator. Commit that to memory. Case 5. A 9-month-old male admitted with hyperammonemia, ammonia 520, plus vomiting and lethargy. OTC deficiency is suspected, and the team sends a full plasma amino acid panel. Which pattern best fits OTC deficiency? Read the 4 options carefully. The direction of each amino acid matters. The answer is A. High glutamine, low citrulline, low arginine, normal to low ornithine. Walk through the logic. Glutamine rises because it mops up excess nitrogen. Citrulline is low because the OTC block prevents its synthesis. Arginine is low as a downstream consequence. Ornithine sits just upstream and may accumulate slightly or stay normal. The options with high citrulline point to citrullinemia or argininosuccinic acid urea, not OTC. This 4-part pattern is the biochemical fingerprint of OTC deficiency, and the table shows how it contrasts with the other urea cycle disorders. Case 6. A 4-day-old male neonate, comatose, with a respiratory alkalosis and an ammonia of 1,200. Plasma amino acids show high glutamine, very low citrulline, very low arginine, and here's the twist. Urinary orotic acid comes back normal. That normal orotic acid is the key. Given everything, what's the diagnosis? The answer is D, CPS1 or NAGS deficiency. The decisive clue is the normal to low urinary orotic acid, which tells you the block is proximal to OTC. With CPS1 or NAGS down, carboxyl phosphate is never made, so nothing shunts into the orotic acid pathway. Remember, OTC and CPS1/NAGS share low citrulline, low arginine, and high glutamine. Orotic acid is the only thing that separates them. So the workflow is hyperammonemia plus low citrulline, check urinary orotic acid. High points to OTC, normal or low points to CPS1 or NAGS. Case 7. A 10-day-old full-term male with suspected OTC deficiency arrives in the PICU. Ammonia is 980. He's lethargic, hard to arouse, and actively seizing. Weight 3.5 kilograms. This is a true emergency. Of the 4 options, what is the single most urgent initial priority? The answer is C. Immediately start IV nitrogen scavengers plus IV arginine plus a high caloric infusion. This is a stat intervention. IV sodium phenylacetate and sodium benzoate, Amino, open an alternative route for nitrogen excretion. IV arginine hydrochloride supports the cycle. And a high caloric glucose and lipid infusion, at least 120 kilocalories per kilogram per day, halts the catabolism that's generating more ammonia. Protein is stopped, but only for 24 to 48 hours. Oral therapy is far too slow here, and a liver biopsy doesn't treat anything. Critically, if ammonia is above 500 or there's cerebral edema, add hemodialysis. And in neonates, that means CVVHD. Case 8. A 3-year-old boy with OTC deficiency is on chronic oral sodium phenylbutyrate. His mother asks how the medication actually clears ammonia from his body. Of the 4 mechanisms listed, which one correctly describes sodium phenylbutyrate? The answer is B. Sodium phenylbutyrate is converted by beta oxidation in the liver to phenylacetate, the active metabolite. Phenylacetate conjugates with glutamine to form phenylacetylglutamine, which the kidneys excrete in urine. Because glutamine carries 2 nitrogen atoms, each molecule removes 2 nitrogens, and it bypasses the broken urea cycle entirely. Contrast that with sodium benzoate, which conjugates with glycine to make hippurate and removes only 1 nitrogen. The drug doesn't inhibit gut ammonia, doesn't reactivate OTC, and doesn't chelate ammonia. It provides an alternative excretion pathway. Case 9. An 18-month-old girl with late-onset OTC deficiency, a symptomatic carrier female, is now stable and ready for discharge. The Metabolic team is designing her long-term nutrition plan to keep her stable and still support healthy growth. Which dietary strategy is most appropriate? The answer is A, an individualized low-protein diet plus essential amino acid supplementation plus L-citrulline. This is the foundation of long-term OTC care. The protein restriction must be individualized, never zero. Option B is actually harmful because a growing child needs amino acids for growth, and zero protein drives catabolism. Essential amino acid supplements meet those growth needs safely. L-citrulline is preferred over L-arginine, better intestinal absorption, and it efficiently raises plasma arginine. It goes around 200 milligrams per kilogram per day. Protein allowance is then liberalized with age as metabolic control stays stable. Case 10. A 7-year-old boy with OTC deficiency, stable on sodium phenylbutyrate and a low-protein diet, Suddenly presents with confusion, vomiting, and behavioral change. Ammonia 620. 2 history points stand out: a fever 3 days ago and valproate started 2 weeks ago. What's the most likely precipitating factor? The answer is D, valproate therapy combined with febrile illness, both increasing the nitrogen load. Valproate is genuinely dangerous in OTC. It directly inhibits the OTC enzyme and independently causes hyperammonemia through carnitine depletion. It should never be prescribed in known or suspected OTC deficiency. The febrile illness adds a second hit. Fever drives catabolism, breaking down endogenous protein and raising the nitrogen burden. Other agents to avoid in these patients include L-asparaginase, topiramate, corticosteroids, and prolonged fasting. Case 11. A 3-month-old male with neonatal onset OTC deficiency has had 3 hyperammonemic crises despite maximum medical management. Genetic testing confirms a hemizygous pathogenic OTC variant, and early signs of developmental delay are appearing. The team is considering liver transplantation. Which statement about transplant in OTC deficiency is most accurate? The answer is C. Liver transplant prevents further hyperammonemic crises, but does not reverse pre-existing neurological damage. This is the key counseling point. The transplanted liver supplies functional OTC, so crises stop and protein restriction can be liberalized, but any brain injury that already occurred is permanent. That's why timing is critical. Earlier transplant means better neurodevelopmental outcomes, because the longer hyperammonemia has been allowed to act, the more irreversible the damage. Transplant is indicated for neonatal onset disease, recurrent crises, and progressive decline. Exactly this patient. Case 12. A 28-year-old woman on postpartum day 5 with 3 days of confusion, severe headache, and vomiting. She's breastfeeding. Ammonia 410. 2 history clues. She's disliked meat since childhood, and her brother died in infancy with brain problems. What's the most likely diagnosis? The answer is A, a symptomatic OTC carrier, a heterozygous female, symptomatic because of X inactivation skewing toward the mutant allele in her hepatocytes. 15 to 20% of carrier females develop hyperammonemia. The postpartum state is a classic high-risk trigger, catabolism plus the hormonal shift. Lifelong meat aversion is a key historical clue, the body protecting itself from a protein load. The brother's infant death points to an X-linked pattern, and ammonia 410 confirms metabolic decompensation. In any adult with unexplained encephalopathy, think urea cycle disorder. Measure the ammonia. Case 13. 2 neonates, both diagnosed with OTC deficiency at day 3. Neonate A peaked at ammonia 800, but normalized within 24 hours. Neonate B peaked at 900, but stayed elevated for 6 days. The peak values are similar. Which factor best predicts their long-term neurodevelopmental outcome? The answer is B, the duration of hyperammonemia before normalization. Duration, not peak level, is the strongest predictor of neurodevelopmental outcome. Prolonged elevation beyond roughly 72 hours leads to irreversible cerebral edema, neuronal loss, and white matter injury. Under 24 hours, a good outcome is likely. Beyond 72 hours, the risk of irreversible injury is high. So neonate A, despite a real crisis, has the better prognosis because the ammonia was cleared fast. The clinical message is simple: treat fast. Every hour matters. Case 14. A 6-year-old boy with OTC deficiency on sodium phenylbutyrate and a low-protein diet is metabolically stable, ammonia consistently under 80. His parents ask what needs to be monitored long-term. Which option is the most comprehensive monitoring plan? The answer is D, regular ammonia, amino acids, glutamine, nutritional markers, neurodevelopmental assessment, and liver ultrasound. This is whole child care. Track ammonia with a target under 80 and glutamine under 1000 as an early warning of drift. Follow nutritional markers: albumin, prealbumin, zinc, selenium, vitamins, because of the restricted diet. Neurodevelopmental assessment catches cognitive and behavioral issues early. Liver ultrasound screens for hepatocellular adenoma, a recognized long-term risk. And growth, height, weight, head circumference, every visit. Biochemistry, nutrition, brain, and liver, all together. Before we close, if you're finding these case-based reviews useful, join the Pediatric Case Review community. Every lecture is organized by body system for easy navigation. All presentations are available as downloadable slides for offline study and self-assessment, and you get direct access. Just comment below and we'll message you with the details. It's built to make your exam prep and clinical review as efficient as possible. Let's bring it together. 6 takeaways. 1. OTC deficiency is X-linked recessive, the most common urea cycle disorder, severe in hemizygous males with variable carrier females. 2. Think urea cycle disorder early, unexplained hyperammonemia, respiratory alkalosis, and normal glucose in a neonate. 3. Urinary orotic acid is the key, separating OTC from CPS1 and NAGs. 4. Act fast in crisis with IV scavengers, arginine, high-calorie support, and dialysis if ammonia exceeds 500. 5. Duration of hyperammonemia matters most for outcome. 6. Avoid the triggers: valproate, fasting, protein loads, infection, corticosteroids. Thank you for learning with me today. A quick reminder, these lectures are educational and don't replace current guidelines or specialist input. Always consult those for real clinical decisions. The references are on screen, including gene reviews, the Haberle urea cycle disorder guidelines, and the ACMG ACT sheets. If this was helpful, follow Pediatric Case Review for more case-based pediatric lectures, and leave your questions in the comments. See you in the next one.